Hey listeners, did you know this episode of med-surg Moments is eligible for CE credit? After you listen to the episode, you may claim 0.5 CE hours by following these easy steps. First, log into the AMSN online library at www.library.amsn.org. Then complete the evaluation for the podcast episode and submit to earn your certificate. The Academy of Medical Surgical Nurses is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. There are no relevant financial relationships with ineligible companies for anyone with the ability to control the content of this episode to disclose. Enjoy the episode.
On this episode of med-surg Moments,
we're exploring the question, do you know what you don't know about pain management?
We have a very special guest with us today, June Oliver, the president of the American Society for Pain Management Nursing.
If you only measure pain by intensity, that's like only describing music by the volume.
I was recently injured at work, and I've been through some of this, so I have a whole new respect for pain management.
There's really three things that go together kind of as a triad to get effective assessment. Neuropathic pain tends to have particular descriptors attached. A lot of prescribers have not worked as a bedside nurse. They don't understand the decision process that you're faced with. A lot of our patients are coming to us already afraid of opioids. Everybody's read the news. They need to understand that if they don't control their pain, they're bound.
this is Marcella,
Eric?
Trish,
Hello.
Sydney.
and Haley. Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud med-surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
We've all been there. That moment when a patient's pain doesn't respond as expected. Unexpected side effects pile up, and suddenly the plan stops making sense in the middle of a busy shift.
Don't worry, you're not alone. In this episode, we're exploring the question, do you know what you don't know about pain management?
We're unpacking the blind spots that can quietly impact our patients' comfort, safety, and outcomes.
Fortunately, we have a very special guest with us today to help us navigate this big question, June Oliver, the president of the American Society for Pain Management Nursing.
June is an advanced practice nurse and clinical nurse specialist with 26 years of pain management experience. She is certified in pain management through ANCC with advanced practice recognition through ASPMN.
With a 20-year foundation in adult critical care as a staff nurse and educator, she now cares for inpatient and outpatient clients with acute and chronic pain at Swedish Hospital in Chicago. June currently serves as president of the American Society for Pain Management Nursing. She's also a frequent national speaker and published contributor sharing her passion for advancing expert pain assessment, safe and effective whole-person pain care, and public and legislative support for patients everywhere. June, it is an honor to welcome you to med-surg Moments.
Thank you so much.
June, before we dive into our conversation, we'd love for you to share your story with our listeners.
I grew up in Rockford, Illinois. It's about 90 miles outside of Chicago. I wanted to be a nurse since I was a little girl. I was always attracted to medical TV shows and any kind of study of the human body. Granted, there might have been a little bit of, shall I say, romanticized versions from some of the literature of that day in terms of stories like Cherry Ames and Sue Barton, student nurse. But nonetheless, the passion survived, and it always was a fit in terms of understanding healthcare, the body, and intervening in a positive way. I did various kinds of nursing, med-surg, home health, and then landed in critical care, which I enjoyed for 20 years as a bedside nurse as well as an educator. I got into pain management accidentally. There was layoffs at the hospital I was working as a critical care educator. I was in the middle of graduate school at the time, and the new job that I got was clinical nurse specialist for med-surg nursing. And the director at the time told me, she goes, okay, we don't know what nursing is supposed to be doing for this, so it's your job to figure it out. And I was like, okay, how should I do that? She goes, well, we have an anesthesia residency here, so just call them up and see if you can talk to them. I started rounding with the anesthesia pain group, and really, I did not know what I didn't know. In critical care, we were trying to keep people alive. A lot of them were unconscious. There was some pain management, but it wasn't, at that time anyway, a sharp focus. And so I gradually had my eyes open to, oh, wow, there's more to this than I thought, and then got really intrigued with understanding it deeper and seeing the need as well as the response when somebody could understand and intervene appropriately. I've been in pain management then for the last 25 years.
That's awesome, Miss June. That's really awesome. So why is nursing pain assessment so important? And is there a better way to assess pain beyond the simple intensity ratings?
That is a great question. And of course, assessment is the foundation for everything. Pain, yes, but everything else as well. And yes, there's really three things that go together kind of as a triad to get effective assessment on what you're going to build your interventions in. Intensity, function, and pain character. Intensity, everybody knows. The 0 to 10 scale became very popularized in the early 2000s. And while it was an improvement from previously very vague questions about how's your pain? Is it okay? Well, what does that mean? So 0 to 10 gave a little bit of objectivity. But if you've worked in healthcare for a while, you've probably noticed that it's far from perfect. Patients interpret 0 to 10 how it makes sense to them, not necessarily how I understand it as somebody reading the literature. And sometimes they put in their own emotional overlay, not necessarily trying to deceive us, but if they say the pain's too low, then they fear you won't pay attention to them. So the 0 to 10 intensity is limited. It's what we call unidimensional. If you add to that function, that means how is the pain interfering with the things you need to do? ADLs, ambulation, coughing and deep breathing, getting your dressings changed. How is the function and the pain interacting? So if the patient says they have terrible pain, but they're walking 400 feet down the hall without any grimacing, you're like, function is pretty good. I need to consider that rather than just going to the highest dose available to me. And then along with that is character of pain. If it's the traditional regular pain that we call nociceptive, that is our traditional opioids and NSAIDs. But if it's neuropathic, we need anti-neuropathic agents. And sometimes that neuropathic pain doesn't respond to our typical kind of interventions. And so the last thing I'll just say about that triad, intensity, function, and character, if you only measure pain by intensity, that's like only describing music by the volume. It's an incomplete picture, and it's not the foundation that we need to then intervene appropriately.
You led right into what I was going to ask you about. I have been so fascinated with pain management. I really want to get pain management certified, but I'm a little hesitant because I remember I took the little pre-test and I said, I don't even know half these words. It kind of scared me. But I just looked at it again this week. So, I'm really interested in it. But you brought up neuropathic pain, and that's one thing I always had a little trouble dealing with because it's not something like that typically responds to the typical pain medications. What could you tell us about neuropathic pain, and how do you see a nurse assessing it and addressing it?
Excellent question, and we can help you with that certification. We have a certification prep course that will equip you to take the exam. We also have other resources that I will mention too that you can access on our website, even without being a member. It's www.aspmn.org. So it's part of our mission to help equip and educate. Neuropathic pain can be defined a few different ways, but it's in contrast to what we call nociceptive pain. So nociceptors are specialized nerve endings in all of our bodies whose job it is to tell you that hurt. Stop doing that. Move away. That's their job. Neuropathic pain are nerves that are not nociceptors, usually, that have been damaged in some way. You can be damaged from metabolic processes such as diabetes, from surgery, being cut, being stretched, being entrapped from scar tissue, etc. And so these nerves start sending out ectopic messages, meaning they're yelling, they've gone rogue. Besides doing their normal function of sensory motor, whatever their assignment is, they're now yelling. We're not healthy. This hurts. Neuropathic pain tends to have particular descriptors attached to it. Burning, tingling. Some people say like ants crawling. Some people say it's icy cold. Those are clues. The thing is, and here's where the med-surg nurse, who really is the gatekeeper to really the whole team, I think, getting the full description of what the patient's saying, because they may tell you. But if we don't ask them, they don't know what to volunteer. So how is your pain? 0 to 10. How can you walk? Okay, fine. But character, don't forget. What does the pain feel like? Is it sharp, stabbing? That's a typical nociceptive kind of pain, even aching. Does it burn? Does it tingle? Does it feel crawly like insects? Does it feel icy cold? And the other thing that neuropathic pain sometimes does is shoots. It may shoot. It may feel electrical or sudden escalations, like it's kind of okay, it's maybe medium, and all of a sudden we'll get these like stabs that are severe and they don't last long. Those are clues that this has probably got at least a neuropathic component. And you can have a combination of nociceptive pain, which is regular kind of pain, and neuropathic pain. So these are the questions that the nurse can play a huge role in terms of asking the patient. And when you ask and you get some of those answers, the other thing that the nurse can do, if it's on your radar, is you can test for something called allodynia. Allodynia is pain from a non-painful stimuli. So if I just stroke your hand, light touch, that should not be painful. If I stroke your hand and it feels like sandpaper or fire, that's not normal. That would be allodynia. And so the nurse can ask about the quality and character of pain, and then they can say, where does it pain? Where is your pain? And touch along that area, not pushing. I'm talking about just light touch, and compare it where the area of pain is to another area where there's not pain. Then you can call the prescriber and go, hey, you know what? This patient seems to have a mixed nociceptive and neuropathic pain presentation, and we need to address the neuropathic pain because opioids alone and NSAIDs are usually ineffective.
I was recently injured at work, and I've been through some of this, so I have a whole new respect for pain management. That's why I'm so fascinated with it. And that kind of happened to me. They put screws in my foot. Everything I learned was from a book, right? So it's like 0 to 10. Yeah, okay, 0 to 10. That's what we know. But when you touched it with like a feather, it felt like I was being electrocuted. It was the worst pain I've ever had.
Yeah, neuropathic pain can be overwhelming. And classically, you'll see it post-thoracotomy if you're working with those kind of patients, because the chest wall is rich in intercostal nerves, and they're going to get cut and stretched. And most of the time, they repair normally. Sometimes they don't. And sometimes in the acute period, they're all ramped up and they may or may not tone down. But it sounds like you, Eric, had a neuropathic component there and needed some attention, some medications that address that specifically.
Talk to us about multimodal analgesia and how the nurse can promote that.
That's definitely a term that gets thrown around and we need to understand what it means. And so basically we're using medications, and it can be non-pharmacologic interventions as well. But for our time together, talk about medications primarily that have different mechanisms of action. And when we put them together, it's like attacking pain from the right flank, from the left flank, from the front, from the rear. So we get a better response when we put them together kind of as a team, and we can use usually lower doses of each of those medications because we're not asking one to carry the whole load. And if you use lower doses, you get less side effects. So it's a nice little bundle of benefits of better pain control, lower doses, at least potentially, and lower side effect profiles. In order to do that effectively, what I usually recommend is the non-opioids be scheduled and the opioids be PRN for a typical kind of situation. And here's where I love to work with med-surg nurses. So we have a patient who's post-op knee replacement or any kind of abdominal surgery, and they've got PRN. They're taking orals now, PRN ibuprofen, PRN Tylenol, and maybe a PRN oxycodone, and they call for pain. What is the pain? Well, it's a 6 going on to a 7. Function is impaired, and there's no neuropathic pain. So they need something. Now you've got 3 PRNs. So which one are you going to bring is your first question. I want to talk after I finish this one, though, about dosing to numbers. But when you've got 3 PRNs, it doesn't make a lot of sense. And if the patient's having a lot of pain, the nurse is usually going to bring the opioid. So in order to do effective multimodal management, a lot of times prescribers don't seem to understand this. The nurse needs to help them understand it. Schedule the non-opioids. Schedule that Tylenol, 1,000 milligrams, 3 times a day. Don't make the patient ask for it. Schedule the ibuprofen or the naproxen or the Celebrex. Don't make them ask for it. Don't make the nurse go, well, I'd like to give them the Celebrex along with the oxy, but I'm only supposed to bring 1 PRN at a time, which I don't know who wrote that rule, but that seems to be what most people feel. So to just avoid that conflicting decision tree for the nurse, a lot of prescribers have not worked as a bedside nurse. They don't understand the decision process that you're faced with from your policies, from your manager, and from the patient's need. So you need to call them. As I tell my med-surg nurses, call them. Tell them, let's schedule these medications that are non-opioid. Maybe they won't need as much opioid because they'll be getting it regularly. Right. So those are some simple things that the nurse can take the lead in. And it's not obvious. It's not obvious to the doctors. It might be to an advanced practice nurse who's worked at the bedside, depends on what their experience is. And the last thing about multimodal is if we have neuropathic pain, then we need agents like gabapentin or pregabalin. Those are the typical classic anti-epileptics. That's medications, and they tone down the activity of nerves. They're just giving less messages. In combination with that, though, can be very effective, something that has a norepinephrine reuptake inhibition. So norepinephrine is a chemical in the body that tends to enhance what we call descending modulation. So the brain sends signals down from the brain to the periphery, like just tone it down, especially with nerves for the norepinephrine. So we want more norepinephrine combined with our anti-epileptic can give us a nice anti-neuropathic outcome. So the norepinephrine would be things like tricyclics, amitriptyline, nortriptyline, duloxetine is kind of our favorite in terms of the antidepressants. And there's some other ones, but those are some of the common ones.
Jean, you kind of touched on it a little bit, but can you guide us through what we need to know about choosing the right PRN analgesic and ensuring proper dosing for patients?
Yeah, that's a big question. And of course, the nurse is the one at the bedside there looking at the orders and going, I wonder if this is appropriate and which one shall I pick? There are a few standout principles for opioids to keep in mind. One would be any contraindications, particularly for that particular drug. Morphine is not really good for somebody with kidney disease. You should use something else like hydromorphone, maybe fentanyl, or if it's oral oxycodone. Morphine has active metabolites. That means that after it's metabolized in the liver, the byproducts are still delivering some analgesia as well as some side effects. And the metabolites last hours. I cannot offhand tell you how many hours, but like 12 plus hours. The parent drug may only last, depending on the dose, 2 to 4 hours. Those metabolites are cleared by the kidney. And if your kidneys are working fine, they don't build up. If your kidneys are not working fine, those metabolites, because they last so long, are going to build up and can lead to oversedation and side effects from the opioid. So that's one good thing to keep in mind. And the right PRN analgesic and the proper dosing is a good segue to the concept of not dosing to pain intensity alone, which we mentioned before. And I would direct you to the ASPMN website. We have some really fine position papers and some publications that talk about range orders as a preference to dosing to numbers. So if you're getting orders like 1 tablet of Norco for moderate pain, 2 tablets for severe pain, PRN, and they're both Q4 hours PRN. Number one, it's really not practical because in some ways their pain is moderate now, but in an hour they're having physical therapy. They had their knee replaced and it's going to be severe as soon as they get up. So if I document that I'm giving the 1 tablet for moderate pain now, because that's how the patient's rating it, it's not going to be effective for their therapy. But if I fudge it and say, well, I'm going to say that they have severe pain, then it's a little bit of an ethical dilemma because you're not recording what the patient said. So it's just not a good system in terms of dosing to numbers. The other problem is if you dose to numbers like that, you can end up stacking the doses in a way that's unsafe. So if I gave the 1 tablet at 12 noon for moderate pain and 1 hour later, for whatever reason, the pain is now severe and the order is 2 tablets for severe pain, then I give them the 2 tablets at that 1 hour later mark. That means within 1 hour, they got 3 tablets. And that wasn't the really intent of the order. So a range order, 1 to 2 tablets, PRN pain is my ideal. If you have to put in, like some systems require something, so then I'll say, okay, PRN moderate to severe pain, because usually we don't give it for mild anyway. That lets the nurse use a more holistic assessment. What is the intensity? What is the function? What is the character? And did they have relief with 1 tablet before? Maybe I don't know. So I would start with the lowest dose, and our range paper on our website explains this in very clear detail. Within the time period that you would expect that first dose to be effective for an oral, usually wait an hour. If it's not, you give the remaining dose of that prescribed range. And then your Q4 hour measurement is always starting from that first dose. So it's very clear. And I think that that's a much superior way to manage and order pain. Unfortunately, not all hospital systems or prescribers understand that. But most nurses, once we have that policy and practice in place, like that much better. And it gives nurses some credit for assessing the situation. Pain is not just a number.
That sounds like a great strategy. I am smack in the middle between Philadelphia and Baltimore. So substance misuse is rampant. Opioid addiction, of course, is an issue. What is the strategy that you recommend for administering opioids safely?
Sadly, substance use disorder has been a big issue in our country, and it affects cities, rural, rich and poor, and every ethnicity. We're all vulnerable. Addiction is not simply a disease of exposure. This is often misunderstood. Yes, it's exposure to a rewarding substance, but in a vulnerable person at a vulnerable time. If addiction was simply disease of exposure, how many people in this country would be alcoholics? How many people have been exposed to alcohol? We have to keep that in mind so that we don't overreact and take the pendulum too far, like nobody should get any of it versus everybody should get everything. Yes, there's risk, but risk for addiction is not the same for everybody. Some of the factors that have been associated and researched would include genetics, psychiatric comorbidities, particularly if they're uncontrolled, unaddressed, and social stressors, social relational stressors. And we do have risk tools if you want to look at them in the literature. I don't think we use the risk assessment tools so much inpatient. We use them outpatient more in terms of there's risk tools like SOAP, there's DAST that measure the risk of misusing the opioids. And then there's some tools that measure the actual risk of opioid use disorder. Opioid risk tool is one of them. But for, I think, the bedside, particularly inpatient setting, we have to also remember that uncontrolled acute pain increases the risk and can lead to chronic pain. A lot of our patients are coming to us already afraid of opioids. Everybody's read the news. Some of them are trying to not use anything, even though the pain is bad and limiting function. They need to understand that if they don't control their pain, their body knows that you will get a stress response. You will get a sympathetic response. And we know that in the central nervous system with severe pain, even after like 24 to 48 hours of poor control, we start to get cellular changes, the way the body is transmitting those messages. And sometimes that can lead to what's called central sensitization, where it's become a pathway, a pattern, where the brain is like, oh my gosh, we have pain. Oh, we have pain. And that pathway gets trodden and messages get sent over and over again. So we need to educate patients that appropriate use is a good thing. When their pain goes down and they don't need it anymore, we'll wean off. And I ask them oftentimes, so if your pain went away and your pain wasn't bad, would you still be asking for opioids? Would you still be asking for a narcotic? Oh, no. I said, well, then you're not misusing it. You're using it for an appropriate reason. And in the outpatient setting, if we're on opioids, we monitor prescription monitoring program, drug screens, etc. But in the hospital, it's more important, I think, that they understand that they need to get their pain controlled and use this appropriately. And people that come in already with a substance use disorder can be rather confounding to staff. They have opioid tolerance if they're actually misusing and have addiction to opioids. And then they have, huge abscess or they had some kind of surgery. And then it gets really hard to control the pain because they're already tolerant. And we would add things like subanesthetic ketamine to help bring down some of that tolerance and control some of that pain. But withholding pain medication at higher doses when that's needed for people with substance use disorder does not help them. In fact, it's been shown that that can increase their chance of relapse. If they're trying to not use street drugs, but they have pain and we don't control their pain, what are they going to do?
I definitely see it in the med-surg setting, that implicit bias for those patients. So what do you think about how we can navigate that bias?
The first thing is to be aware of it. So the fact that you're aware of it, Haley, and bringing it up, I think is really the first step. And it would be great to have some facilitated conversations, either with someone in the pain service, or if you're lucky enough in your hospital to have addiction psychiatry, and that they could give in-services or even a brief unit conversation about a patient. I think that can help. So we need to admit when we're uncomfortable. And what are we afraid of? Well, I'm afraid I give them this IV Dilaudid that I'm just contributing to their addiction. I'm making it worse. Or if I just am frustrated because this patient's been here 5 times in the last 5 months and they're still doing their same addiction problems, then we need to, of course, look at ourselves. But we need a team. So psychiatry, addiction psychiatry, if you have it, pain service, and then talk with each other. These are people with a disease, a brain disease. A lot of people have had family members or friends who have had some kind of incursion with addiction, and that can give you a little more compassion. It affects the family, it affects the friends, and it's really not a good place for the patient either. Often they say they start out perhaps using the substance to medicate emotional pain, but then after a while, they're just using the substance so they don't get sick, so they don't withdraw. I have actually had interesting conversations with some of my patients with addiction. If you just ask them, they're often willing to talk. And I think sometimes we're afraid to ask. It feels impolite or like it's a secret. It's not secret. And just say, can we talk a little bit about your substance use history? What is your drug of choice? How did you start? When did you start? Did you have any periods of sobriety? What do you think helped you stay sober? What do you think helped trigger you maybe back into relapse? You just might learn some interesting things and they become more human, struggling with a disease. Talk to them. It's not a forbidden subject. If they don't want to talk about it, they'll tell you. Just say, oh, hey, I'd like to talk a little bit about your substance use history. Can we do that?
With so many pain issues in the hospital setting or the healthcare setting, why don't we see more pain management specialists? Unless it's just my experience, but I've never seen one in the hospital setting.
Are you in a metropolitan area or a more rural area? What's your setting?
No, I'm in Berkeley, California. So many shifts I spend just chasing pain. And it's like, why don't we have someone that can actually specialize or assist with this?
Well, that's a great question. And I don't know if I have the answer to that. That seems like it's a healthcare system kind of question. I guess I've been fortunate, obviously, in the last 25 years to work where we do have pain service because that's what I do. But I will say that just as a trend across the country, from the year 2000, when the first pain standards came out from Joint Commission, the idea of pain control was becoming popular. And there was a rise in inpatient pain services and outpatient pain clinics. And then we all know that there was a rise in opioid overdose deaths, of which there are a lot of misunderstandings. Some of that were pill mills of unethical prescribers. Because I do need to say, before I answer your question a little more directly, if you really look into the literature, it never was the chronic pain patients that were driving those numbers of overdose deaths. There's multiple studies. One of Das Gupta was the author out of North Carolina looking at 2 million patients with chronic pain with opioid prescriptions. Their overdose rate was like 1%. So it wasn't the chronic pain patients, but with the crackdown and the pushback, chronic pain patients also did feel the effect of, well, we're not going to use the opioids as much. But why aren't there more pain services? I think there's been a bit of a reaction now, last 5 to 8 years, of reacting to that overdose rise and some of the CDC guidelines that were amended. But as a reactionary stance to, okay, we did too much pain management, so we're going to pull back.
What I have seen too is a lot of push for outpatient pain management. Have you seen that, June?
Yes, you're absolutely right. Almost everything these days in healthcare is pushed towards outpatient.
Yes,
You know,
that included.
And in areas like Eric's hospital, where we don't have access to those resources of pain management physicians and prescribers, is there a certain place that our listeners can go to learn more about pain management?
well, besides our website that I mentioned before, ASPMN.org, I would direct you to what I think is a great resource that's a free download online. It was published in 2019, but I think it's just as relevant. And it's a government document. It's the HHS/VA Pain Management Best Practices for 2019. You just have to Google it, HHS Pain Management Best Practices. It's like a booklet. It might be 200 pages long, 180 pages long. It's very comprehensive. It goes over gaps, inconsistencies, recommendations. It has patient stories. It's much more comprehensive and balanced, in my view, than the CDC guidelines, which got all the attention, took up all the oxygen in the room. But I think the HHS guideline is much more balanced and informative. So I would recommend that. And also, touching back on the problem with addiction too, SAMHSA, which is a government website, also has information about addiction and treatment centers and contact websites and numbers to look for treatment for addiction in a particular geographic area. So those are some resources that are easily available.
Thank you for sharing those. I'm definitely going to have to check those out. And June, thank you so much for joining us for this important episode. It's been an inspiration having you with us on med-surg Moments.
I'm so happy to have had this time with you all, and I just want to encourage all the med-surg nurses who might listen to this that they really are the backbone of hospital pain management. So know as much as you can and share it with your providers and your prescribers, because what you know and what you do makes a big difference.
To our listeners, thank you for joining us. We'll see you next time.
We look forward to connecting with you on the next episode of med-surg Moments, the AMSN podcast.
In the meantime, we encourage you to subscribe to med-surg Moments wherever you listen to podcasts.
To reach us, use hashtag med-surg moments on your social post.
Or send us an email at amsnpod@amsn.org. That's amsnpod@amsn.org.
We're all AMSN members, and if you love med-surg Moments, we invite you to become a member of AMSN. You can learn more at www.amsn.org.
Finally, the content within the med-surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, this is Sydney,
Eric?
Trish.
Kelly.
Haley.
And Marcella. And always remember, med-surg Moments is a moment in our lives and a moment in our med-surg careers that makes a huge difference.